Welcome to the podcast, Not Your Doc Anymore. I am your host, Daren Watts. Here we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the power of those who understand clinical practice and are in the trenches on a regular basis and have had years of experience. Here to address the topic of infertility is Dr. Shawn Gurtcheff. Thank you so much for being here.
Oh, thank you so much for having me. It's truly an honor.
Oh, you're so sweet. I'm going to just tell you a little bit about Shawn Gurtcheff. Dr. Gurtcheff, who I will refer to as Shawn on multiple occasions throughout the interview, did her undergraduate degree at UC Berkeley in California. She then went to the University of West Virginia to get her doctorate degree in medicine. Then our paths crossed at the University of Utah, where she did her OBGYN residency for 4 years. She then spent 4 years in practice as a general OBGYN and went back to get more training because that's what we love to do, right?
Never ends.
And did a fellowship in reproductive endocrinology. Also during that time received a master's degree in epidemiology.
Clinical epidemiology. Yeah.
Well, let's talk about infertility in some simple terms, if that's okay. How important is timing in the conception process, and what tools or methods can help?
Yeah, that's a great question. Timing's important.
Can we say timing is everything?
We could say that.
Yeah.
We could also say that timing is less important if you're just really, really active all the time. Timing becomes important if you're not with your partner on a regular basis, or if you're just not physically able to be intimate on a regular basis. But multiple studies looking at natural populations have suggested that just more frequent intercourse is associated with a higher chance of natural fertility. But most of us can't do that. We have lives, we have responsibilities. And so then timing becomes really important. And there are lots of tools that are readily available for tracking cycles and tracking ovulation. Every phone now has a cycle tracking app. You can even get fancy ones. You can buy over-the-counter hormone tests that will help you determine if that hormone surge that's coming prior to ovulation, when that's happening. And so if you can only have sex once in a cycle, the time to do that is when you're ovulating, right? And so timing can become really important. So tracking ovulation can be helpful, having sex around that window of ovulation. So sperm can live for several days, up to 5 or 7. And so having sex in that week around the timing of ovulation, ideally prior to ovulation, and then kind of the day of ovulation, and then maybe the next day. And then once the egg releases, it only hangs out for about a day, and then it's out. And so having sperm there ready waiting can really optimize natural fertility. So more frequent intercourse in general is better, but if you can't have sex all the time, like most of us can't, then timing is really critical.
That's great. Before we move on from this topic, are there ovulation tests that you find are better than others? Because I know that you can buy some that are quite cheap. They're just on the shelf. Are those helpful? What exactly is the best way to approach that? I'm not trying to get you to sponsor some brand, but I know that there are some that are better than others.
There are, but honestly, it's kind of whatever works.
Okay.
And for a lot of women who have regular, predictable cycles, the cheap ones are more than sufficient.
Great.
So I think it kind of depends on the woman, because they can get really fancy. Even just the difference between sort of the generic over-the-counter ovulation surge detection and then the brand name ovulation surge detectors, there's a little bit of difference in sensitivity. But you can also buy these watches that check your chloride ion channels in your skin, and they check your E2s and your LHs, and they get really fancy. For the vast majority of women, you don't need that. So if you're a woman that has regular, predictable cycles and you buy the cheap ones and they work for you, then they work. But
That's great.
if they don't work for you, meaning you're not seeing that surge mid-cycle, and usually then it's a problem with the test. If you're having regular predictable cycles, then the test should be turning positive midway through the start of one cycle from the start of the next cycle.
Okay.
So I would say whatever works. And if the cheap ones work for you, great. If you have irregular cycles, especially if you have a hormone condition like polycystic ovary syndrome that's going to affect your natural ovulation, it may be that none of them work. Not that they don't work, but they don't work for you because you may not be making the right hormones at the right time, or you may not be ovulating on your own.
Yeah.
So I would say whatever works, and start with the cheap ones. And if they work, great. And if they don't, then you can try to get more fancy or talk to your doctor.
It's great. I just want to keep this simple for everybody. What is it actually predicting? So I know you talked about chloride ion channels, but what are the majority of tests actually measuring and predicting?
So the ovulation predictor tests that you buy in the grocery store that you pee on a stick are measuring a hormone called luteinizing hormone, or LH. And at the time of follicle development, estrogen levels rise, and that's what thickens the uterine lining. And as the egg is getting ready to release, those estrogen levels peak, and that sends a cascade of hormone signals that make luteinizing hormone surge. So there's a little bit of luteinizing hormone at all stages of the cycle, but just prior to ovulation, there's this huge surge of hormones, and that's the signal from the brain to the ovary to kick out that egg. So when you're peeing on a stick, you're measuring metabolites of luteinizing hormone in the urine. Okay. I get a lot of questions about like, well, what happens if I get my surge, but then it goes away in 6 hours, or I get a surge and it stays positive for like 4 days. That does not mean that you're ovulating for 4 days. That means that you're just metabolizing that hormone a little more slowly, so it's still showing up in your urine.
That's great information. And that typically predicts ovulation how much later if you get the peak?
Typically a day to 2 days. So remember when we talked about like it's good to have sperm there ready waiting? So having sex on the day that you get that positive surge is going to be kind of, again, if you can only have sex once, that's that ideal timing, because then the sperm is there ready waiting when the egg actually releases a day or two later.
Gotcha. That's so great. Just to put expectations or set expectations appropriate, what are the fertility rates typically associated with each cycle?
Setting expectations is half of our job, right?
Yeah, right.
So I tell people when everything is perfect, healthy young couple, normal fertility, no fertility issues, when everything is perfect, the best we can expect is a chance of pregnancy of about 25% any given cycle.
Wow.
And then that drops pretty dramatically as we get older. And that means like the woman is ovulating, no health issues, all things are good. And I think a lot of people don't really understand that, right? Because we all know people that got pregnant accidentally or got pregnant their first try. And you just have to remember that for every normal person that got pregnant their first try, there's another perfectly normal couple that it took 6 months.
Yeah. It's the same person that started working out at the gym for 2 weeks and lost 5 pounds. Yeah.
Right.
This is a huge question, and feel free to speak. I'm sure this is a conversation you have every day. But what are the most common causes of infertility in men and women?
Yes, this is a conversation we have every day. So about a third of all fertility that we see in the US is male factor. About a third is female factor, and then about a third is kind of a combination of factors.
Okay.
The most common reasons for male factor infertility involve sperm abnormalities. It might be hormonal. It might be a physical issue, a blockage, a varicocele, which is a dilated vein in the testicle, or sometimes it can be related to environmental exposures or medications or other therapies. Genetic issues are rare, but possible. And so the evaluation of male fertility typically starts with just a basic semen analysis, and then we kind of go from there. If it suggests low counts, that could be hormones, it could be a physical issue, imaging, examination, etc. For women, there's just a little bit more to it, right? We have to have eggs, they have to be releasing regularly, and then we have to have like normal reproductive plumbing, for lack of a better word. And so when we evaluate female fertility, we're looking at ovulation, and ovulation issues are probably one of the most common issues for women. The most common reason for ovulation issues is hormone dysfunction, right? Miscommunication between the brain and the ovary. The most common reason for that is polycystic ovary syndrome. Ovulation issues, and then functional issues like issues with the tubes, growths in the uterus. The most common reason for blockage or a tubal function issue is an inflammatory condition called endometriosis or in prior infection. So how we evaluate female fertility typically starts with an evaluation of, are they ovulating? History, physical exam, hormone testing. And then the other thing that kind of falls under that umbrella of ovulation is, does a woman have eggs, right? Because men make new sperm from puberty until they die. And women are born with pretty much all the eggs we're ever going to have. And we go through puberty and we start releasing them. And even when we're not releasing eggs, there are many, many that are still dying over time. And then we go through menopause. And basically, we have a set reproductive lifespan from puberty to menopause that men just don't have.
Right.
So when we look at, do we still have functioning eggs, and are those eggs going to be healthy? We're also kind of looking at, where is a woman in that timeline? Is she average for her age? Does she have better egg reserve than her age? And we typically look at that with blood testing and ultrasound.
It's great. Great comprehensive answer. What are some misconceptions about infertility that you are encountering on a frequent basis?
Oh gosh, just calm down and you'll get pregnant. Just stop trying and you'll get pregnant.
Yeah, that is the worst, isn't it?
Be less stressed.
Yeah. That stresses you out more.
Right.
Mm-hmm.
Yes, absolutely. There are certain significant physical stressors that can affect fertility, right? So if a woman is severely underweight, we see this in like professional ballerinas.
Yeah.
Their hormone milieu is such that they basically lose that brain to ovary communication and they stop ovulating. They stop having menstrual cycles. It's called hypothalamic amenorrhea. And so there are some stressors that can actually affect fertility, but the normal day-to-day stress, right? The normal day-to-day, like, oh my gosh, I've got 20 different things to do and, not enough time to do it. And my mom is sick and my work is crazy and all the things. I would usually tell people there's not good evidence that those sorts of daily stresses that we encounter all the time have a significant impact on fertility for the vast majority of people.
Awesome.
At the same time, doesn't help. Being chronically stressed is not good for your general health. And so really trying to encourage people to practice self-care and give yourself some grace and some time and go easy on yourself and try to prioritize good general health, which includes diet and exercise and healthy sleep and all the things that we should all be doing anyway.
Yeah. How are they actually measuring that? Have there been any studies looking at the stressors on the impact of fertility?
Yes, there are some really interesting things coming out about like chronically elevated cortisol levels and its effect on health in general, but specifically fertility. And then measurements like C-reactive protein, which is kind of a general measure of general inflammation, has been shown to have some correlation with fertility. But it's not like, these things are so complex, and like cortisol levels naturally vary dramatically. So it's not like checking a cortisol level is going to tell me if you're too stressed.
Right.
Right. And it's affecting your fertility. So it's really interesting, and there is a lot coming out, but nothing that's really ready for like prime time that's actually going to help me help someone.
Would you say that sometimes the stressors occur significant enough that have to affect your menstrual cycle before you kind of consider that a massive stressor? I mean, obviously blood testing is not there yet either.
Yeah. So I would say absolutely. If it's affecting your menstrual cycles, it's going to affect your fertility, right? It's affecting your ovulation, it's going to affect your fertility.
Yeah.
And the jury is probably still out about, are there more subtle ways that we just don't know, and we don't have good tools to detect it.
Yeah. Okay. That's great. How does endometriosis impact fertility? I know you mentioned that a little bit, but what treatment options are there?
Yeah. So endometriosis is a really complicated disease, right? Our current
Hmm.
understanding is that it's an inflammatory condition and probably immune system related, but we tend to think about it as a hormone disorder because those inflammatory cells are sensitive to hormones. And the treatments that we currently have available primarily affect hormones. So, any hormone state that is high in estrogen, because estrogen is very pro inflammatory, is going to make endometriosis worse. And any hormone state that is low in estrogen or high in progesterone is going to help endometriosis. So, things like birth control, which is high progesterone, or medications that lower estrogen, like Lupron, or Orlissa, or those medications can be beneficial for preventing exacerbation of endometriosis and can help pain long term, but they also prevent ovulation. And by definition, when you ovulate, you're going to make estrogen. That's just what our
Hmm.
bodies do. And so there's a bit of a disconnect between what therapies we have for endometriosis and specifically trying to get pregnant, because most of the medical therapies we have to treat endometriosis symptoms also preclude pregnancy just as a side effect. So generally, when endometriosis is the problem, and if fertility is the primary goal, then fertility treatments, whatever we can do to help you get pregnant the fastest, because then once you're pregnant, lots of
Hmm.
progesterone is going to help suppress that endometriosis. Once you're nursing, low estrogen is going to help suppress that endometriosis. So it's basically, from a fertility perspective, just whatever we have to do to help you get pregnant as quickly as possible.
Great.
And then long term, we can look at other treatments for sort of keeping it suppressed or managing other symptoms.
Great. Well, my goal is to have some of this reach not just patient and listeners, but providers as well. And so, does surgery impact the outcomes of fertility if you're doing that for endometriosis?
That's a really good question. And our current understanding is probably and
Hmm.
definitely in cases where the endometriosis is severe. So, stage 4 endometriosis, there's good evidence that surgery is beneficial. The problem is you don't know if a woman has stage 4 endometriosis and without going in surgically and looking,
Yeah,
right? And obviously surgery is a fairly major undertaking and there's risk
sure.
involved. So from a fertility standpoint, if the endometriosis is suspected to be mild or moderate, like stage 1 to stage 3, the evidence for surgery to improve natural fertility isn't that great. And generally speaking, fertility treatments are more effective.
Hmm.
But there's lots of reasons why women might choose surgery over fertility treatments. Sometimes it's cost or insurance coverage. Sometimes it's just they want a definitive diagnosis, and we still have no other way to definitively diagnose
Yeah,
endometriosis, right? So some women will choose surgery even if it's not the most efficient way to help them get pregnant. But yes, so for women who have stage 4 endometriosis, surgery has been shown to be beneficial for sure. And then for women for whom fertility treatments are not successful, like women who've had repeated IVF failures, there's some evidence that surgery can be beneficial. There's
hmm.
also evidence that like long-term hormone suppression prior to repeat IVF is beneficial. Have you heard of this new test called the Receptiva DX test? Was
I
that
have
something that
not.
you've used?
No.
So there's an inflammatory protein called BCL6 that if it's found in high quantities in the uterine lining, there's like a 96% correlation between elevated BCL6 and implantation failure with IVF.
Wow.
And there's about a 90% correlation between BCL6 and either endometriosis or some other inflammatory condition like hydrosalpinx.
Wow.
And in women who have tried IVF and had repeated embryo implantation failures, if you have a positive receptiva and you treat it either with laparoscopic excision or fulguration of endometriosis or 3 months of strong hormone suppression with something like Lupron
Yeah.
prior to another transfer success rates double. It's
Wow.
right. It's kind of exciting. So it's
That's
on one
great.
hand, it's not a diagnostic test for endometriosis, which we need, right?
Yeah.
On the other hand, it's really useful, especially in this population of women for whom other things have failed. So it's kind of cool, and it's relatively new, and we're hoping that we're hoping to have a non-invasive diagnostic test for endometriosis soon. But in the meantime, we have this Receptiva test.
So do you collect it by doing an endometrial biopsy?
Biopsy. Yep.
Okay.
It's collected through an endometrial biopsy in the luteal phase. And that's kind of the hard sell, is because you can't try to get pregnant that month.
Yeah.
And as you know, trying to tell a woman who's desperately trying to get pregnant that she can't try that month is like a dagger through the heart. But for a select population of women, it's a cool test, and it's been super useful.
Yeah, just for everybody, the luteal phase is the latter part of the cycle, right?
Latter part of the cycle, yes.
Okay, great.
Yeah. So you obviously, if we're disrupting the uterine lining after ovulation, we could be disrupting a pregnancy, and we can't. Yeah. So you have to prevent pregnancy.
That's great. All right. Thank you. Good information. How does age impact fertility in both men and women?
Age impacts fertility, unfortunately, in both men and women. It's a lot more subtle in men, and it starts a little later. So for men, it's a fairly subtle decline that starts in the early to mid 40s. And we see it in slight changes in sperm parameters, like maybe slightly lower counts or slightly poorer motility. We also see slight increased risks of things like autism in children from men over age 45. But again, it's subtle, and that increased risk is just a couple percentage points. It's significant in women, and it starts actually in the late 20s and gets more steep of a decline in the mid 30s. And then for most women, somewhere in the early 40s, fertility generally falls off a cliff. Not to say there aren't 48, 49-year-old women who can successfully have babies. They're just the exception and not the rule.
Sure.
So at age 32, 90% of women are fertile. At age 42, 90% of women are infertile, just based on their eggs. And it's really unfortunate, especially for those of us who waited to start their families. But that doesn't mean there's no help, right? There is help. It's just a lot of the things that we can do to help women in their later reproductive years aren't necessarily the things that they envision, right? So fertility treatments can be beneficial. In a lot of ways, fertility treatments can help speed up the process. So where it normally might take 6 months to a year to get pregnant, fertility treatments can sometimes make that happen a little sooner. But at the end of the day, fertility treatments still rely on having good eggs and good sperm. And it's really hard to get good eggs from women in their 40s, especially in their mid to late 40s.
And there's also an impact on miscarriage rates as you age as well, aren't there?
Yes, absolutely. So what we see as women age and the changes that happen in their eggs are basically chromosome errors and an increased rate of chromosome errors in their eggs. And if you remember, probably back from your last genetics class, how long ago was that? Long. So eggs and sperm are the only cells in the human body that have one copy of every chromosome. All of our other cells have 2 copies of each of 23 chromosomes, right? That's what makes us human. And that 23rd pair is 2 X's if we're female, generally, or an X and a Y if we're male. And so eggs and sperm are the only cells that split their chromosomes so that then they can come together and each contribute one of those pairs. And then that fertilized egg has 23 pairs of chromosomes, right? One of each of the 23 from the egg and one of each of the 23 from the sperm. So eggs are really unique. And as I mentioned, like women are born pretty much with all the eggs they're ever going to have, and they just sit in this sort of immature state, and they have 2 copies of every chromosome. And as they get ready to release, they double their chromosomes, and then they split them twice. And so they go from 2 to 4 down to 1. And that multiplication and division of chromosomes just becomes more dysfunctional as we get older. So we end up with lots more eggs that are missing chromosomes or have extra chromosomes. And the vast majority of those eggs don't make babies. And they might not make babies by just not making a pregnancy, or they might not make a baby by resulting in a miscarriage, a pregnancy that results in a miscarriage. And so, yes. So for example, a woman getting pregnant at age 25, her fertility per month is 25%, and her chance of miscarriage when she gets pregnant is less than 10%. at 40, the odds of a conception in a single cycle drop from 25% down to sometimes less than 3 to 5%. And the chance of miscarriage in the mid 40s is as high as 50%. So it really is a dramatic change.
That's huge. That's great. I wish you were teaching my genetics class years ago. That was awesome. Okay, so now that we're on the topic, there's a perfect lead into the next question, which is how can genetic testing be useful? So we talked about the role of genetics, but how can we test for it, and do we?
Yeah, that's a great question. And this is totally an aside, but there's a movement in the reproductive endocrinology and infertility community to take out some of the reproductive endocrinology from our training and add in genetics. And there have even been some colleagues who have been advocating for we should be called infertility and genetic specialists.
Oh, wow.
Because so much of our jobs these days is related to genetics and talking about genetics. It's fascinating. And it's all things that I've had to learn after the fact.
Yeah.
So there's two different kinds of genetics, the way I think about it when you're talking about fertility and building families. And one is the genetics that we pass on, right? So do we carry genetic mutations that mean that our children are at high risk of having some sort of genetic disease? And we understand that by getting family history or their genetic issues that run in our families, or do we ourselves have some sort of genetic condition? But most of us don't have a family history and don't have specific genetic conditions, but still could be at risk of passing on genetic mutations that cause disease, because a lot of the genetic diseases that are seen are recessive, which means that you have to have 2 bad copies of that genetic mutation in order to make someone sick. But we might silently carry just one, but because we have the other one that's healthy, we're not sick. And so if you have a couple planning a pregnancy and you both happen to be carriers of the same recessive genetic mutation, then they have a high risk of having a child with that condition.
Yeah.
And there now exists blood testing of like panels of hundreds of recessive genetic mutations that it's just a simple blood draw. We offer that to everyone, not that infertility puts you at higher risk of being a carrier of a recessive genetic mutation, but just because you're there and we're talking about stuff and we want you to know it's available. And a lot of OBGYNs and primary care docs are now also offering that to their patients that are starting to try. And I think it is great. And I don't think it's for everyone. And there are a lot of people who say, I would love my child no matter what. And that's wonderful.
Yeah.
We just want to make sure that people know that it's available so that if they do want to do that testing, they have the opportunity. And then if we find that they're a carrier of a genetic mutation, then they have options. And they have more options before they get pregnant than they have once they're already pregnant.
Yeah. How's the pricing been for that? Has it been pretty reasonable?
The genetic carrier testing, yes. So the screening that you can do is usually covered by insurance. And if it's not, most companies have like a cash pay price of a couple few $100s.
Okay.
If you're going the route of actually like testing embryos and doing pre-implantation genetic testing, that is still ridiculously expensive.
Is it?
But we're actually seeing more and more insurances pick up cost.
Interesting.
I think they're realizing that it's cheaper to pay for pre-implantation genetic testing than it is to pay for a child who has genetic issues, right?
Yeah.
And it's really fascinating. So one of the recessive genetic conditions that we can screen for is something like sickle cell anemia. And there are now, with CRISPR technology, which is the gene editing technology, there are now actually treatments for children to like CRISPR technology has been used to go in and edit their genes with success. There are developing genetic treatments for people with genetic mutations for some of these things. And part of me thinks maybe as therapy gets better and better, that embryo testing is going to be less necessary and less useful. But those medical therapies that are currently available are hundreds of thousands of dollars per year. And they're lifetime therapies.
Wow.
At least that we currently have. And hopefully that will change. But so when I think about $25,000 to $50,000 to do IVF, to do pre-implantation genetic testing, it's a lot of money, but it's a lot less than hundreds of thousands of dollars per year for an entire lifetime.
Wow.
And so anyway, I think insurance companies are starting to get wise to that.
Mm.
But also we're just seeing more insurance coverage for fertility treatments in general,
Are
which
you?
is exciting. Yeah.
That's great. Wow.
Yeah.
How effective are lifestyle modifications in improving your fertility outcomes, Shawn?
I would say can only help,
Okay.
but are probably not going to cure most causes of infertility. That said, it depends on what the issues are. And something like ovulation dysfunction absolutely can be worsened by the hormone environment that comes with excess weight. So
Sure.
for women who are overweight, sometimes weight loss can have a dramatic improvement in their ovulation. Even just a 10% lessening of body weight can
Wow.
improve ovulation in like 30% of women. So it really depends. But I would say it can only help. And so focusing on maintaining a healthy body weight, being active, eating a healthy diet, right? Like avoiding sugar and processed food as much as possible. And I do what I say, not what I do, right? Because it's hard. It's hard. It's
Yeah.
hard for everyone. But trying to focus efforts on fruits and vegetables and lean fat or lean proteins and healthy fats and trying to minimize processed food and sugar can have a dramatic improvement, especially for women where, that's the main issue. And men too.
Yeah.
Obesity changes our hormones. Higher estrogen in men can decrease sperm production. So it can have a dramatic improvement. Tobacco, pretty much in every form, but especially smoking cigarettes, is awful for fertility. Excessive alcohol use, other drugs. We're learning more about marijuana. It's not good.
Mm.
Yeah. So lifestyle factors can have a dramatic impact. We're also learning more and more about environmental exposures. We know that chemicals in the environment, specifically like BPA and plastics in general, those chemicals are hormone disruptors and they can have a negative impact on fertility. Similarly, we know that bad air quality can affect fertility. Now, that
Yeah.
said, living where we live, bad air quality is a constant issue at certain times of the year. And most people along the Wasatch Front are not struggling from infertility. But if you're already struggling, it's probably not a good idea to go out for a 10-mile jog when the air quality is terrible,
Mhm.
right? So we know that there are things out there. We're learning more and more. Pesticides can affect fertility, definitely certain chemical exposures, especially if your job is in manufacturing, et cetera. We just don't know a lot about the nuances, but we're getting more information every day.
It's great. I think at this point in the interview, I just have to say to private, most people listen to this rather than watch this. But if I were your patient and I was watching your smile for you telling me all this information, you need to do all these things, I'd say, absolutely.
I'll do whatever you want.
I'll do it. It's so good. Okay. What should couples consider before deciding to undergo fertility treatments?
Yeah, we would encourage a couple to seek help if they're young and they've been trying for a year, or if they're older, like a woman's over 35 or a man's over 40, and they've been trying for at least 6 months, or sooner if there's any other concern. If you're a woman who does not have predictable menstrual cycles, you're probably not ovulating. You do not need to wait a year before you seek help. Please don't wait a year. And if somebody tells you that you should wait a year, you go talk to somebody else.
Yeah.
And then once you come in, then we take a history, we do a physical. What are the basic fertility evaluation? Sometimes I can take a history and kind of know where the big red flags are and where we need to focus efforts. But most of the time, we recommend a general evaluation of every couple because we just never know. And even if that we know that there's one problem, it doesn't mean there might not be other problems. So that would be my recommendation, is ideally sooner rather than later. It doesn't mean we have to go down the rabbit hole of all these crazy treatments. It's more about just getting the information and figuring out where we are and then deciding together if it makes sense to move forward or to just give it more time.
Okay. That's great. What kind of treatments or any kind of workup do you like to see done, and you answered a little bit of this, but by just a general OBGYN, or I think we're seeing certified nurse midwives do this kind of stuff before
Yeah.
they come to see you.
Yep. So obviously, I will see anyone at any phase of their journey, but it
Sure.
makes our discussion a little more efficient if they've had basic testing. So for a man, a semen analysis. For a woman, ideally a basic blood hormone panel that looks for egg reserve, AMH. Thyroid is helpful, especially if they have menstrual cycle abnormalities. And then just honestly, just making sure that they're healthy for pregnancy. So, like a basic prenatal panel, typically we verify blood type and vaccine status and the basic stuff, right?
Great.
And then ideally a pelvic ultrasound just to evaluate for any hidden pathology. We can't see everything there is to see, but it gives us a pretty good idea. And then some sort of evaluation of the uterine cavity and the tubes. And we typically do that through an X-ray dye test called a hysterosalpingogram or HSG.
Right.
But they can also be done through something like a saline sonogram.
Mm-hmm. That's awesome. Tell me what your feelings are about Clomid and general OBGYNs, nurse midwives doing those kind of treatments. Is that good? Is that bad?
So I think for an anovulatory or oligoovulatory woman, right, so someone who's not ovulating regularly on their own, those medications are often all that they need. And I think it is wonderful if their primary care doctor or general OBGYN feels comfortable prescribing those.
Great.
I would say for a woman who's not ovulating, if she's ovulating on medication and she still hasn't gotten pregnant within 6 months to a year, then I would be referring fairly quickly, because the point of the medication in an anovulatory woman is to get them ovulating, right? So if they're ovulating and they're not getting pregnant, then something else is going on.
Yeah.
And then the other thing I would ask is just do something to make sure that they're ovulating. And that could be as simple as you're having them track their cycles and do basal body temperature charting, although that's not super accurate, but it's better than nothing, right?
Yeah.
A cheap, easy way to confirm ovulation is with a luteal phase progesterone level. So like a blood draw around cycle day 21-ish. Yeah. Just something to say, yes, the medication is effective, you're ovulating, so that then if you're not pregnant within a time frame, 6 months-ish, we move on. Yeah. The other thing specifically about Clomid is there's recent evidence that repeated exposure to Clomid over a lifetime increases the risk of this certain type of non-cancerous but not quite benign borderline ovarian tumor. And so we do hesitate to use it for an extended period of time in most women, but there are alternative medications like letrozole, which is my favorite for ovulation induction. Right. If you are prescribing, just be aware that's a risk. And it's not a good medication to be on indefinitely, right?
That's great. So a semen analysis, this was sometimes my frustration when I was working as a general OBGYN, that people would come in and say that I had a semen analysis. Are there things that you want to see on that semen analysis that are more helpful than others?
Yeah. So a semen analysis is not a perfect test, and it does not prove or disprove male fertility.
Yeah.
But a normal total motile count is the best predictor of natural fertility. So if you have to multiply the concentration by the volume times the percent motility and get like a total number of swimming sperm, basically.
Okay.
And if that total number of swimming sperm is above 10 million, then you're in pretty good shape. 20 is even better.
Awesome.
But again, I like to think of a semen analysis as a very basic test, right? And I use this analogy with my patients all the time. Sperm is like a delivery vehicle. It's like the UPS truck, right? But it's not actually what's making the baby. What's making the baby is the DNA inside the sperm. And so you could look at a UPS truck and it might be banged up, but the packages inside are still perfectly okay, right? So a semen analysis is all about, can the sperm do its job of delivering its packages? But then whether or not those packages actually make a baby is a lot more complicated. We just don't have a perfect test. So it's what we have, and it's useful in some ways, but it's not the end all be all. There's a newer testing called sperm DNA fragmentation testing that can give us a little bit more of a window into the DNA inside the sperm. but it's also not a perfect test. And it's really only been found to be useful in very rare circumstances of poor embryo development with IVF. But I think more is coming.
Yeah.
The whole field of male fertility has exploded in the last 10 to 15 years. We're learning so much more. When I was in training 15, 20 years ago, a lot of our guys got ignored. It was really sad. We just didn't think a lot about male fertility, and that has
Yeah.
changed a lot. I think with the realization that it actually is important and sperm are important. The egg's probably a little more important, and a good egg can make up for a not so great sperm. The reverse is not true.
What are the currently available assisted reproductive technologies? I don't know. Do you refer to it as ART?
We pretty much just refer to everything as fertility treatments.
Okay.
And then it's like medication, surgery, IUI, IVF.
Okay, great. How do they differ? Can we talk about all those?
Yeah, absolutely. So, I mean, in a perfect world, we have a couple come in, we find the problem, we fix it, and then they never need us again.
Yeah.
Unfortunately, that doesn't happen all that often, but it's really satisfying when it does.
For sure.
So for people for whom we find the problem, but it's not something that's fixable, or if we just can't find a problem, and about 10% of couples that we see, it's unexplained. That's when fertility treatments are really useful. And generally it's medication, either to promote ovulation or promote sperm development, or it's a combination of medication and artificial insemination. We call IUI, intrauterine insemination. And IUI is where we take the sperm and take it in the lab and put it through a prep and get just the good swimmers into a small volume and then place them directly into the uterus at the time of ovulation or around the time of ovulation. That's IUI. And we'll often do that in combination with some hormone manipulation and kind of promoting ovulation with something like Clomid or Letrozole, and then getting the timing just right, possibly with either really good ovulation tracking or a trigger shot of a medication called HCG, which sort of mimics that natural LH surge and allows us to time the IUI, and then potentially some supplemental progesterone in the luteal phase if we think that that's an issue. So that's IUI. We're not superseding nature, right? We're just maximizing natural fertility at each phase of the menstrual cycle. And then there's IVF, and IVF completely supersedes nature. We're taking the eggs outside of the body, putting them together with sperm in the laboratory, letting the egg and sperm grow into embryos, and then putting an embryo back in.
Yeah.
And part of the reason it supersedes nature is it just takes a lot of the things that make natural reproduction inefficient and bypasses them. So we don't have to worry about, are the egg and the sperm finding each other, right? We're literally putting them together. And then we almost always do it in combination with medication to what we call super ovulate, or make the ovaries release multiple eggs at once. And so if we get 10 to 15 eggs all at once, well, that's like a whole year's worth of trying all at once. Mm-hmm. And so success rates with IUI typically top out at about 20 to 25% per try, but over a few tries can still give us good success rates. IVF success rates are typically in a good prognosis patient more like 60% per try and 90% over a few tries. Wow. And when I say good prognosis patients, the age of the egg really is a huge determinant of prognosis.
Right.
So for women under 37, those success rates are really good. IVF success rates by age 42 to 43 are less than 10%. Right. And just as a function of the egg health.
And then how about intracytoplasmic sperm injection? Is that something you're doing?
Yes, for sure. So intracytoplasmic sperm injection is a laboratory procedure at the time of IVF. So I mentioned we take the eggs outside the body, put the eggs and sperm together in the lab, let them grow to embryos. There's basically two ways to put the eggs and sperm together. And one is we just put a little egg in a droplet of media and throw a couple 100,000 sperm at it and let them do their thing like natural selection style. And the other is ICSI, or intracytoplasmic sperm injection, where we literally pick up a sperm and put it into the egg. And ICSI revolutionized success rates for IVF when there's male factor infertility. So I mentioned natural fertility. We need like 10 or 20 million swimming sperm. even to have good success rates with IUI, ideally we need above 5 million swimming sperm.
Wow.
To have success with IVF, we need 1 sperm per egg.
Wow.
Not 1 million, 1. It's incredible.
Wow.
It's so incredible that for a time, a lot of IVF clinics were just routinely doing ICSI on everyone. And that's when we sort of learned that actually it's great for a lot of people, but it's not always the best thing. And it can be kind of tough on the eggs. So if you have older eggs or fragile eggs, sometimes ICSI can be harder on the eggs and result in poor embryo development. So it's definitely not a panacea. But for couples where the primary concern is male factor or there's a fertilization issue, it has opened up IVF success for a lot more patients. When IVF first came out, it really was only helpful for women who had tubal factor infertility, right? Because you're just bypassing the tubes. But with the advent of ICSI and then later good techniques for embryo freezing and thawing, and now with egg freezing and thawing, it's revolutionized the field and improved success rates for a much wider array of patients.
It's great. How many sperms? Sperms. How do you say it?
Spermies.
How many spermies? How many spermies do you actually put in the medium when you're doing IVF? I know it takes one, but how many are you putting in there?
Yeah, so a typical prep will be a couple 100,000 in each droplet of media. Yep. And obviously it depends. If a guy has normal semen, he probably has 10 or 20 or more million sperm in a prep.
Yeah.
And so they just concentrate it, put it through a density gradient prep, and and then put a droplet in the media. And then the whole process that happens naturally in your body or in a woman's body is happening like in the lab where a bunch of sperm are swimming towards that egg and then calcium ion channels open and a few of the early sperms start to open those windows and then the lazy sperm gets in at the end and that's the one that wins.
Gosh, so many lessons in that. So many
I know.
lessons.
So we call that conventional or microdroplet insemination. And about half of our patients are good candidates for that. As I mentioned, like conventional insemination sometimes is a little gentler on the eggs, but sometimes eggs that have thicker shells, zonas, can do better with ICSI. So it really is kind of a nuanced decision. It's not a one size fits all kind of thing.
That's great. Gosh, so I've never even heard of those things. So that's awesome. Good insights. What are some non-traditional or complementary therapies that people explore for fertility?
Yeah. So I think we routinely recommend lifestyle interventions, right? Diet, exercise, good sleep. Counseling therapy can be really helpful. Not that it's going to cure your infertility, but it can help a lot of people deal with it. And treatments are tough, right? Dealing with infertility is tough and going through treatments are tough. And having a therapist or having someone who's on your side, got your back through the process can be really helpful. Acupuncture can be helpful. So I did a stint in physical medicine and rehab my 4th year of medical school, and I actually trained to perform acupuncture.
Wow.
And it was really fun. It was a really cool thing. So I tend to encourage it in my patients maybe a little more than others. But if I have a patient who's like deathly afraid of needles, she's probably not going to do well with acupuncture.
Sure.
And the data is mixed. There's some studies that suggest that it is beneficial for fertility. There are other studies that say that maybe it's not as beneficial. There's definitely nothing that has said that it's harmful. But I feel like just in general, like with massage or other self-care, if it helps you relax, if it helps you process the situation, and maybe it helps improve blood flow, all of those are great. I'm a fan of acupuncture. I think massage and other just sort of general good self-care is really helpful. And then there's like a whole rabbit hole of vitamins and supplements. And if you ask Dr. Chat GPT, he's going to give you a list of about 50 different vitamins to be taking. And I struggle with that a little bit. We know that folic acid or folate supplementation is beneficial prior to pregnancy. Vitamin D seems to be really helpful. So we will often recommend our patients be on extra vitamin D. We know omega-3 fatty acids are really important. But the rest of it, honestly, it's just better to get it through a balanced diet. And the problem with vitamins and supplements in our world is that they're not regulated and we don't really know what's in them. And things like heavy metals can be really bad for us and they can contaminate vitamins and supplements and we just have no way of knowing. So I don't tend to recommend a ton of extra supplements, but there is a little bit of data that suggests that some of the antioxidants like CoQ10 and high-dose vitamin C and vitamin E can be beneficial in certain circumstances.
Interesting. Wow.
But you just have to be careful with that stuff.
Yeah. Okay, that's great. Good information. What is the process, Shawn, and success rates of egg donation? It's loaded.
Yeah. Egg donation is a highly effective therapy for couples where the issue is the eggs. And for the majority of women in their mid to late 40s, that is the issue. Egg donation is extremely effective, assuming that your eggs are the eggs that are being donated are coming from a healthy young woman. So whereas IVF success rates in an average 42-year-old woman might be 10% per try,
Wow.
with egg donation, success rates are more like what we would expect to see in a woman who's in her 20s, right, in the 60 to 70% range.
Right.
And it's not to say there aren't other issues that can come up for older women, but the vast majority of the issues that we see for women trying to get pregnant in their later reproductive years is in the eggs. So for egg donation, basically a woman, a donor, will go through the process of IVF up to the point of the egg retrieval. So she goes through the hormone injections, she goes through the trigger injection, she goes through the actual egg retrieval procedure. And then those eggs either are fertilized with the recipient's sperm or they are frozen. And egg freezing has now not been experimental for about 15 years. And it's fairly standard practice.
Great.
And it is technically challenging. Eggs are single cells that are very large. They're the largest cell in the human body, and they have a very high water content. So the older technology that we used to use 20, 30 years ago for freezing embryos and sperm and eggs resulted in a lot of those cells lysing. Wow. So there's a new technology that's been standard for maybe 15 to 20 years called vitrification. And freezing is kind of a misnomer. It's more of a dehydration and flash freeze.
Okay.
And with vitrification, 90+% of those eggs come through the freezing and thawing. And once they come through the freezing and thawing, they're just as likely to make babies. And there are now egg banks where there are just like frozen eggs sitting around,
wow,
ready for women to pick a donor, just like there have been frozen sperm banks for decades.
Yeah.
So now, probably for the past 10 years or so, there have been frozen egg banks that are pretty standard. And if you are a couple in need of an egg donor, one option is to use a friend or a family member, and we can walk through that process. When you do that, it's always a little bit of a loaded situation, right? Because there are legal issues and there are psychological issues. And so we help you walk through that process. But the other issue is when a couple picks a donor, they pick a donor because they're a friend or a family member, or they're someone that they trust and that they know. And that doesn't always exactly correlate with that person's going to be a good egg donor, right?
Yeah.
It doesn't mean she has healthy eggs or great eggs or is going to be great through this process. So when we pick donors, we try to pick good people that also are going to be good donors. So they go through pretty rigorous medical screening as well. And they have genetic testing, they go through psychological evaluation, and before they go through the donation process. Mm. So we still have kind of the old school option of what we call fresh egg donation, where a donor goes through the process and the egg and sperm are put together without being frozen. But more than half of egg donation cycles are now done with frozen eggs from a bank across the country.
What kind of data is actually available to consider when you're considering an egg donor? Is it hair color, ethnicity, like where they got their college degree?
Yeah.
I don't know. Is that all that stuff in there?
All that stuff is in there.
Wow.
And it's all online now. And it's not that I'm too old to have done internet dating, but friends that they tell me it's like internet dating. It's like a whole profile, and you get demographic information, not anything identifying necessarily, right? Unless this is an open situation. But you have height and weight and eye color and hair color. And then you have genetic history and you have family history and you have the psychological evaluation, and they write a paragraph about why they wanted to be an egg donor.
Wow.
And you get education. And I always tell people, like, there's so much information, sometimes it's almost overwhelming.
Yeah.
And so you almost have to go into it thinking about, well, if I'm using an egg donor, what characteristics are important to me in my egg donor? And the other funny thing is, we know a lot about genetics, but we don't really know how much of anybody is genetics and how much is
Yeah,
environment,
sure.
epigenetics. And we know that the genetics are the basic building blocks, but it's epigenetics that's going to determine which of those genes get turned on and which get turned off. And so genetics are important. And when you're using a sperm or an egg donor, you want to think about those things. But just because your donor is 6 feet tall doesn't mean that your child is going to be 6 feet tall. And just because your donor has blue eyes does not mean that you're going to have blue eyes.
Yeah.
And some people pick donors because they just get a good feel for them. Others pick donors because they want to match physical characteristics with their family. Others pick donors that are particularly athletic or creative or educated. And it's really interesting to help people through that process because sometimes these are really weird things to think about, right? Most of us don't think about those options, except we do when we pick our partner, right?
Yeah, for sure.
Sort of interesting.
Yeah.
But yeah, so lots of information available. And then I always tell people if there's information that you feel like you need in order to make a decision, we know these donors personally. We can reach out and ask questions. So if you want to know exactly what they studied in college or what their grade was in chemistry 1A or whatever it was, we can ask those questions. But our clinic's program is a non-directed program, which is the terminology we use for anonymous. We don't use anonymous anymore because in this day and age, the whole concept of anonymity is basically out the window, right? All your child would have to do is send their spit to 23andme.com and they're going to find genetic relatives.
Yeah.
And that's something we also counsel people about. Building families through egg donation or sperm donation or embryo adoption is this really unique and beautiful way to build families, but it's also got some really interesting kind of different types of issues that we can help people navigate.
Gosh, this has been priceless. I'm kind of jealous that you get to talk about this all the time.
I had a patient tell me yesterday that I was a wealth of information. I was like, that's really sweet. I've been doing this for a long time.
That's so great. Really is good. Okay, I don't know how much information you have about this, but what factors should be considered before pursuing international fertility clinics or surgeries?
I would say that is outside of my area of expertise, but just as a professional, I would say you have to trust where you're going and who you're doing it with, and you have no recourse. I think that's the scary thing, right? If there's a problem, if there's a mistake, if there's a complication, there's no system there to support you. And that scares me.
Yeah, it does.
So be careful. Most of the patients that I've had that have gone internationally are people that are international people, right? Like patients who maybe one of the partners grew up in a different country, and so then they go back to their home country, but they know how to navigate that system and they know the pros and cons of that system.
Yeah.
I think as an American with no ties who's just going out of the country for medical care, be cautious.
Yeah. Okay. Good advice. Wealth of knowledge still continues. What emotional and psychological impacts are commonly associated with infertility, and how can individuals and couples cope? And I know you're not a therapist, but I know that we definitely play a larger role of therapy than we thought we would.
Yeah, that's such an important point and such a good question. And I refer to a lot of therapists because infertility, just the diagnosis of infertility, has been associated with as high a stress as a cancer diagnosis. And these are young people who up to this point haven't been told that they're not invincible, right? And so this is often their first realization that bodies can break or bodies don't always function perfectly, and it can be devastating. So anxiety is very high, depression is very high, and therapy is extremely useful, to the point that we have a whole list of therapy referrals in our new patient packets that we give to everybody and I walk through. And friends and family can be wonderful to lean on. And obviously partners can also be really important to lean on. But what people don't necessarily understand is that everybody has their own personal experience, right? And so when you're talking to friends and family, they're going to be bringing in their own personal experiences, and it's probably not the same as your personal experience. And the nice thing about therapy is it's this extra unbiased person who's just there to listen and help you with
Yeah.
tools for coping. And those are so valuable. And even intimate partners, they're dealing with it too,
Yeah.
right? It's their
Sure they are.
diagnosis as well. And as wonderful as partners can be, we don't always cope in the same ways.
Yeah.
I wish we all had a therapist.
Yeah.
We all need a therapist.
That's a good answer. I love it. What advances in fertility research and treatments are on the horizon? What can we anticipate?
Oh gosh, there's a lab in China that has taken skin cells from mice and turned them into egg cells and fertilized them.
What?
It's crazy. I don't think that's going to be ready for humans anytime soon,
Wow.
but people are looking at this. Probably the most interesting things that are on the horizon now are around the field of genetics in reproductive medicine. And I mentioned CRISPR technology, which maybe not everybody is knowledgeable about, but it's basically gene editing. And in the US, it is not legal to gene edit embryos and then use them to make babies. But there are still labs in the US that are experimenting with it, not to the point of making babies, but at least in the lab. And there are people in other countries who are working with it. In terms of general fertility treatments, we're getting better and better. IVF success rates have improved by 20 to 30% just in my career.
Wow.
And we're getting better at making it more efficient and less costly. Mm-hmm. So that's exciting for people who need aggressive fertility treatments. It's just more accessible for more people these days.
Yeah.
And I hope that we're learning more about how our environment plays a role. I think we're just on the cusp of understanding that it does.
Yeah.
But how exactly it does and what are we going to do about it, I think is still a ways away.
Yeah. So that increased fertility rates is in the presence of implanting fewer embryos, because that's also changed as well.
Yep, absolutely. That's a great point. Yes. So we've just gotten a lot better at knowing what embryos need for early development and then how to pick out the ones that really have the highest potential.
Yeah.
To the point that now we're often picking out one that has high potential. And yes, so we've gotten more effective, more efficient with fewer risks from things that come from transferring multiple embryos and ending up with multiple pregnancies. And you were on the receiving end of the brunt of that, having to deal with complications from multiple pregnancies as an OB provider.
Yeah. So have the twin rates then also declined in that?
Yeah,
have they?
Significantly.
Wow, that's great.
Yeah, when I was in training, twin rates from IVF were in the 30 to 40% range. And now they're down to less than 10%.
Wow.
And even less than 5% in a lot of practices.
How amazing. That's really good.
Yes and no. I have a lot of patients who would love twins.
I know. They don't know what they're getting into, though.
Well, yes, you need to tell them that. And I tell people all the time, I think twins are adorable. I'm not against you having to buy 2 cribs and 2 car seats at once, right? Yeah. My concern is getting them here healthy.
Yeah.
And that's the issue, is how many twins have we lost at 24 weeks or have long-term health issues because they were born early and that we could have prevented if we could have prevented that.
Yeah.
So if a couple has 2 healthy embryos, they are much more likely to get 2 babies if they put them in one at a time.
Yeah. That may be the reason that insurance companies are wanting to get into the fertility business, because they are having less risk of twin or multiple.
In fact, our guidelines are very clear, but as you know, guidelines aren't laws, and many insurances that pay for IVF will mandate single embryo transfer, and they just won't pay for it if you don't do it.
Interesting.
Yeah.
Wow. Okay, these are all loaded questions, but you're doing great answering them. Why might some couples choose fertility preservation, and what does that involve?
Yeah, that's a great question. So the sort of historical indication for fertility preservation was if one of the members of the couple was going to be undergoing some sort of treatment or therapy that was going to render them sterile.
Right.
And cancer treatment is probably the thing that everybody knows, right? Many cancer treatments result in sterility or have a high incidence of sterility. And so freezing eggs or freezing sperm in advance of that can preserve fertility.
Great.
Nowadays, it's become a little more common for men and women to preserve their fertility as they age. And we often encourage them to think about that. For women getting into their early to mid 30s who aren't ready to actively start building their family, or for men in their 40s, same thing. Freezing eggs and sperm can give you fertility past sort of the age at which age starts to negatively affect fertility.
Yeah. Okay. That's great. What are some ethical considerations surrounding fertility treatments and technologies?
Oh, that is a loaded
That is
question.
loaded.
So my clinic has a corporate parent, and our corporate parent has an ethics committee, and I sit on the
Great.
ethics committee, which is really cool. A lot of universities have ethics committees, and I just always found it really fascinating. But a lot of the university ethics committees don't specialize in reproductive ethics. So it's a lot of like end of life care and declining treatment and that kind of stuff. So our ethics committee is just clinical reproductive ethics, and it's anybody in our network can bring a case that they think is sort of interesting.
Wow.
And then we review that case and look at guidelines, and the American Society for Reproductive Medicine has an ethics committee, and they publish guidelines. And so it's really fascinating, kind of the things that come up. I'm trying to think. We had a recent case where we had a couple who wasn't necessarily on the same page about wanting treatment. And the female partner was asking her physician to lie to her male partner about the treatments that were happening. And then there were some cultural issues, and it gets kind of sticky, right? Because as a physician, normally we have a patient, but as a fertility physician, you have two patients, two adult patients. As an obstetrician, you have your mom patient and your baby patient. And sometimes there's a conflict of interest, right? So those things come up. Our field has gotten a little political, or we've been in the news a little more than I like recently. In Alabama, I don't know how much you heard about this, but in Alabama last year, there was a fairly restrictive anti-abortion law that went on the books. And it was so restrictive that it actually affected the practice of IVF, because they talked about,
cryopreservation,
embryos and cryopreservation of embryos. And it basically shut down the practice of IVF for a time until the politicians realized that this was a problem, and sounded like an unintended consequence. But I think there are some really challenging ethical issues for individuals. My goal is to help people explore their own personal values so that whatever we're doing doesn't negate or conflict with their personal values, right? So I've had some patients come to me and say, well, I wouldn't do IVF because if I had extra embryos, I would feel compelled to use all those embryos. I would never want to discard embryos. And so we talk about the process and how it works. And we have the option to potentially just freeze eggs and just use an egg or two at a time so that we don't end up with extra embryos. So it's not a very efficient way to do it. It's actually a very expensive way to do it, but it was the only option they had. And so we were able to make it so that how we were doing things didn't conflict with their values and didn't put them in a situation that they weren't going to be comfortable with. And there is a lot of gray in that. And I think for a lot of people, they haven't necessarily thought about all of this before. And so sometimes it's just really fun to help people explore and kind of explain what we do. And when we explain what we do and the biology behind it, then most people are receptive, or once they understand a little bit more. I think most people don't understand that eggs fertilize all the time in women's bodies and don't make babies.
For
right?
sure.
Anyway,
Maybe 75% of the time.
Yeah.
Yeah.
Right. Exactly.
Possible. Who
Possible.
knows? Yeah.
Right. Exactly.
This is what I refer to as the Delta segment.
Oh.
We are human, and you were an amazing human when I knew you so well in 2000, 2004, and even beyond that. And really, we've had wonderful interactions since. But how has taking care of patients with these conditions changed you?
Oh, wow. I am amazed on a daily basis at people's resilience and strength. And it's an honor to be part of people's journeys. I always tell my patients, like, I really wish you didn't need me, right? I wish you didn't have to be here. But I'm so glad that you're here, and I think that we can help. And it's just an honor to be able to be with them through that journey. But every day gives me hope for humanity, right? Like that people are wonderful and they're strong and they They get through adversity. My day-to-day restores my faith in humanity.
Love it. That's
And then
so
I go
great.
home and I read the news and it just all wrecked again. Then I go back to work and I love people.
That's right. Isn't that true? All right. My last change question is, we know that people that are working and possess the real knowledge of the current medical system are those who are within the system and actually doing the real work, like yourself. If you could change what a lot of people refer to as the broken healthcare system, what steps would you want to make to change the delivery of healthcare to your patients?
Whew, that's tough. That's tough because there are so many pros and cons on all sides, and there are so many competing interests. But I think what I see in my day-to-day is I think we need to remove the middleman from healthcare. I think we need a single payer system, and I think insurance companies cause more problems than they help. And I think it's a travesty that for-profit companies are in between patients and their doctors, or patients and their providers.
The truth.
But I also get that it's really complicated and there are a lot of downsides. And the reason that we have the system that we have is a natural development of the healthcare system. My understanding is out of World War II, right? Like that insurance companies grew out of businesses wanting to provide healthcare for their employees, and then it just sort of snowballed. And the UK went the other route, and they have a nationalized healthcare system, and they're also having problems.
Yeah.
So I recognize we don't know of a perfect system as of yet, but from what I see, the middleman, just a lot of money gets siphoned off in the middle and is not necessarily improving care.
That's great. Well, that's a good answer. Thank you so much.
No, back to you. What are your thoughts?
It's so interesting. We live in such a unique environment as an OBGYN because I think our relationships with our patients and what we do is, to me, so unbroken. I think it's just so amazing. And to be able to, for sure, care for somebody during a pregnancy and to deliver a baby and to be able to be a part of somebody's life, which is actually so vital, I think is just so powerful. I think that the system is really working for pregnancy. That's what I think. I've had awesome conversations with doctors that say government and the hospitals want to be in charge. They want to employ people. They want to make the decisions. And the reality is I don't think they're capable of doing it. That's what my feeling is.
Yeah.
Somehow we need to have physicians that are willing to step up, to spend the time to do stuff like that. And so hopefully I can make a change. I won't do it in city government, but who knows what's going to going on. Yeah. We're going to just have this final charge, which is hopefully people who are listening can use this knowledge to go forward and improve your health. Seek out a healthcare provider like this great Dr. Gurtcheff that can get you the most appropriate care, or urge somebody to do the same. If you're a healthcare provider, go forward with greater knowledge to deliver the best healthcare in what I think is one of the most vulnerable and essential interactions with those who are entrusted to your care. And we need to clarify that the medical advice or procedures, they don't just substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information that we provided generally. And then I just have to say this for everybody. You can find this on Apple Podcasts, and I'll send that to you, Shawn, Spotify, Amazon Music, and also on YouTube at Not Your Doc Anymore. You can also find us on Instagram, at TikTok, at Not Your Doc Pod, or Doc Watts _. And then the last thing I need to say for all those who have made this possible, thank you to Natalie Watts, our president and CEO of Not Your Doc Anymore, LLC, and our social media managers, Taylor Seberg, Emily Brown, Sarah Marion, and our production manager, Joshua Watts.